Hey, Dr. Smith.
Yeah. Oh.
Hey. Ready for another video?
Yes, you caught me getting some vitamin M. Let me go into my office and I'll put my coat on. Okay.
Absolutely.
What is the question today?
Our question today is actually from Carlos, and
Hola.
The question we got today is he's been diagnosed with Ankylosing Spondylitis. I don't even know if I said that right.
Ankylosing Spondylitis.
But if you could give us some insight into what that is and what that means.
Okay. Are you sure we haven't done a video on ankylosing spondylitis?
I don't think so. I checked and I don't think so.
Okay. You're making me miss my breakfast, you know. Ankylosing spondylitis. One of the most common questions I get in the office when people come in is they always ask the same thing. Do I have arthritis? Well, really, when you look at arthritis, there's two major types. You have degenerative arthritis, which is basically arthritis of aging, wear and tear. If you have some aging, if you're alive, you have degenerative arthritis. Doesn't necessarily mean that's the source of your pain, doesn't necessarily mean that it's going to go on to the point that you'll have to have surgery in the future. The other type of arthritis is what they call autoimmune diseases, diseases where the body attacks itself. It produces substances which they're called cytokines, and you have inflammatory cytokines where it attacks itself. That would be disease processes such as rheumatoid arthritis, SLE, ankylosing spondylitis. As far as ankylosing spondylitis, no one actually knows the cause of it. They believe that it is produced by some type of environmental factor that acts upon people who have some type of a predisposing I lost the word, predisposure to catch the disease. I think that's saying the same thing twice, but you know what I mean. It tends to occur more commonly in males than females. It's about 4 times as common in males as females. Usually presents in about the 3rd decade of life. In my practice, I usually see it present as somebody, young adult, that has pain in the lower back, but it usually attacks what they call the axial skeleton, which is obviously what we deal with, the spine. The axial skeleton actually includes the skull and the rib cage too. Ankylosing spondylitis is it's called an enthesopathy, which is a very common word used in medicine, and what that means is it attacks the ligaments that attach one bone to the next bone. In the spine, you have the vertebral bodies. Between the vertebral bodies, you have the discs. Around the disc, connecting the bones together, holding it all in place, is a ligament called the annulus, the annular ligament. That becomes calcified, and so you wind up with a very stiff spine that people describe as looking like bamboo. And as these spines become stiffer, the people tend to bend over. So if you look in a textbook or something and see a picture of somebody with end-stage ankylosing spondylitis, they're going to be bent over like this, kind of looking at the floor. But ankylosing spondylitis is a systemic disease. It can attack the organs of the body. It can attack the eyes, producing uveitis, which is one of the processes that's unique for ankylosing spondylitis. It can attack the lungs really in 2 ways. It can directly attach the lung tissue, I think. And also it can make the rib cage stiff, so people lose pulmonary function or the capacity to breathe well. It can attack the kidneys, produces a protein called amyloid. So you get amyloidosis of the kidneys, you can get renal shutdown. And it also can attack the heart to include the aorta. As far as joints, it can attack some of the bigger joints, such as the hips and the knees. Some people with ankylosing spondylitis wind up having to have their hip replaced. The chairman of my department, when I was back in residency, actually had ankylosing spondylitis and had to have his hip replaced. In fact, he was one of the first people to get the anterior approach to the hip, but now I digress. let's see. Now, as far as diagnosing ankylosing spondylitis, one of the unique features that you see frequently is the fact that people have a positive HLA-B27 and a negative rheumatoid factor. The diagnosis is made, like they do with most of these diseases, by pointing out those things with the disease that are somewhat salient or stick out as and make it somewhat unique compared to the other of the autoimmune diseases. One of the things is this attacks the SI joints, so we can take an x-ray of the pelvis, and we see that the SI joints, the attachment of the axial skeleton to the pelvis, can disappear. Also a positive HLA-B27, as I mentioned, and then the inflammation of the eye called uveitis. The uvea is just a layer of the eye. It's the layer that includes the iris, the ciliary body, and then the coronoid or coracoid. I forget. Don't look at that too close. And so if you have those three things, it's the triad, then you can relatively safely diagnose the patient as having ankylosing spondylitis. As far as treatment for ankylosing spondylitis, in most cases, early in the disease, you treat it with physical therapy to maintain mobility and non-steroidal anti-inflammatory medications such as ibuprofen, Aleve, things like that. As you get more advanced, you have to go to other doctors, not surgeons, but like a rheumatoid doctor that can prescribe special medicines that block those cytokines or the inflammatory cytokines. One of the most common ones is a cytokine known as TNF-alpha, and a TNF-alpha blocker is methotrexate, which is a very common medicine. I think everybody's heard of methotrexate. And that's used for arthritis, that's autoimmune. It affects the immune system by blocking those cytokines. But that's usually going to be given by somebody that can prescribe that medicine, follow the side effects. It's almost like a chemotherapeutic agent, so you need to go to a doctor that does that. As far as surgery, there are some elective surgeries for these patients that have ankylosing spondylitis, but obviously it's a systemic disease, so it's not a surgical disease. It's not a surgical process that you're going to cure with surgery. Some of these patients, as I mentioned, do get kind of stuck in this position where they can only see their shoes, they can't see the horizon. And with those patients, they do osteotomies to basically correct what they call the brow angle, so they can see the horizon. And one of the important things for surgeons like myself to know about these patients is they wind up with a very stiff spine, a very brittle spine that's easily broken, and if broken is very unstable, and these patients tend to bleed very easily. They bleed during the surgery, and if they break the spine, they bleed into the spine, producing what they call an epidural hematoma, which can cause paralysis. So fractures in patients with ankylosing spondylitis are what they call surgical emergencies. And the mortality with these is actually very high. Somebody with ankylosing spondylitis that gets involved in a motor vehicle accident and breaks their neck, for example, I think has a 70% chance of dying. Could be a 70% chance of some neurologic morbidity, but I think it's actually a 70% chance of dying. You can Google that. I can't remember exactly. But the bottom line is ankylosing spondylitis early is treated with physical therapy, non-steroidal medications, and then just is monitored. A lot of people. Then the last thing I'll mention is something that's always mentioned about about ankylosing spondylitis is the HLA-B27. People get an HLA-B27. 90% of the people that have a positive HLA-B27, 90% of people with ankylosing spondylitis have a positive HLA-B27, but also 90% of people who have a positive HLA-B27 don't have ankylosing spondylitis. So it's one of those tests that's used when they're explaining statistical analysis in medicine, so you see it frequently mentioned with that. But that's ankylosing spondylitis. I actually think it's a review. I think if you look at our site, we may have done other videos on that. Possibly, maybe not. If not, this was a pretty good one. I think I answered the question. Thank you. Bye.